Okay, start. Vinigudan, started.
Yes, sir. So welcome all. Arun ille sir. Welcome, Ray.
I don't think so.
Okay. Okay. So let me welcome all of you to the PG Club of IAP Kerala. So IAP Pathanamthitta is happy to conduct this program. So I thank Jose sir for this opportunity. Today, the presenter of this case is Dr. Alvin from Pushpagiri, and the mentor is Jacob Abraham sir. So let me welcome Dr. Arun Maman, President of IAP Pathanamthitta, to this meeting. Arun, you can welcome. You can say welcome.
Respected State President Dr. Joso, State Secretary Dr. Krishna Mohan, State Treasurer, and the faculty of the day, Dr. Jayagumar sir, who is HOD of AIMS Kochi, the mentor of the day, Dr. Jacob Abraham, who is the Professor and Head of the Department of Pediatrics and Neonatology, Pushpagiri Medical College, Tiruvalla. And I also welcome the presenter, Dr. Alvin Thomas, who is currently the Junior Resident, Pushpagiri Medical College, Tiruvalla. And I welcome all those who have gathered over here to hear on the topic development delay. Thank you.
So, sir, can we start?
Yeah.
Dr. Alvin, over to you.
We can start the program. No problem. We can start the scientific content. Dr. Alvin, you can present the topic and you can continue.
Before Alvin starts, I would like to express my sincere thanks to IAP Pathanamthitta and also to Dr. Jose, the president of IAP Kerala, Dr. Jacob and Dr. Shanavas, the convener of the PG program, and all Vinikudan and Arun for giving me the opportunity to chair the session. I know that this is an important program of the IAP Kerala, and this is being viewed by so many postgraduates and faculties, and hope that this session will be beneficial to all of you. And this is an opportunity to interact with the outstation faculties. In that way, this is good. So now let us hear from our JR Alvin. Okay, JR, you may please start.
So good evening, everyone. First of all, I'd like to thank Dr. Jacob Abraham, my mentor, and Dr. Jaykumar and Dr. Jose for giving me this opportunity to present in this platform. And today, I'm presenting the case of Advik Srijit, who is
Alvin, can you show your video?
His video is not there. His video is not there, Jose.
Some issue with your video is not working.
Your video is not there.
1 minute.
If any issue with the video, you can continue. Otherwise, show your video. Then Alvin, any issue with you?
1 minute, sir.
All others need not come live video, but other he has to come if possible. Should be there. Otherwise, there is no one-to-one contact.
You can use the phone for your video. Only thing is you have to mute the computers. And audio. Alvin, okay. Please start.
So good evening, everyone. So today I am presenting the case of Advik Srijit, a 5.5-month-old male child who hails from Changanasheri, whose informant is mother and information was reliable.
Dr.
And this
Alvin,
baby
Dr.
was-
Alvin, one second, because you know that I used to emphasize one important clinical point. It is important to mention about the distance between this hospital and their native place, not only for academic reasons, but for other reasons, you know, that if the patient is from far away place, they can't come back to the hospital within half an hour or 1 hour. So this case, this may not be relevant, and always say that within how many hours or how many minutes they can come back to the hospital in case of an emergency. So that's very important for social reasons. You have to mention that. So I know that Changanasheri is very near to Tiruvalla, but if the examiner is from other places, you know, then he may wonder within how many hours they can come back. Okay, you may please proceed.
So they hail from a place about 10 kilometers from our hospital. And baby was brought with complaints of abnormal movements in the form of flexion of limbs and neck since the past 10 days. And he also had a history of global developmental delay. And hence I would like to start my history from antenatal period.
Dr. Alvin, but I would like to hear from you about the presenting problem. Whether this child was apparently normal prior to the onset of the illness, or how did the complaint started? Before we go to the antenatal history.
Okay, sir. So this baby was this baby with the history of global developmental delay was now brought with complaints of abnormal
The
movements.
parents noticed that child had global development delay prior to the admission also. They are here now
Yes, sir.
for the present. Elaborate the presenting complaint.
Yes. Baby was now brought with complaints of abnormal movements in the form of flexion of neck and flexion of all four limbs in clusters, each lasting for about 10 to 15 seconds, 2 to 3 times per day since 10 days prior to admission.
Dr. Alvin, is there any
Dr. Alvin, you have logged in from 2 devices. Suppose one of these devices.
And the number of spasms increased in frequency and intensity since 3 to 4 days prior to admission, and he was brought here for further management. And there was. Shall I proceed with the negative history, sir?
No, I want to know whether this episode is associated with any fever, any rashes, any other
There is
significant
no history
problem.
of. There is no history of fever, no history of uprolling of eyes or clonic movements of limbs, drooling of saliva or deviation of angle of mouth. There is no history of any regurgitation of feeds. There is no history of reduced activity, no history of any fall or head trauma. There is no history of excessive cry or irritability. There was no history of cough, breathing difficulty, or bluish discoloration of skin or mucous membrane. There was no history of any difficulty in feeding, vomiting, or there was no history of loose stools. There was no history of any contact with fever. And the child had no history of persistent.
One second. There are no pointer symptoms suggestive of involvement of any of the system for this child along with these symptoms. That's what you are saying.
Yes, sir.
So for the in between, child was normal or not? Child was feeding, child was passing urine normally. Was it like that?
Yes, sir. Child was on exclusive breastfeed. Child was feeding well, sucking well, and urine output was adequate. Mother gives history of adequate breast milk. And she usually feeds for about 15 to 20 minutes, and every 2 hours she feeds the child. She
They
feeds for
waited
about
for-
9 to 10 times a day.
They waited for 10 days for to be shown to the pediatrician.
Yes, sir. Initially, they thought it was normal movements, but later when the frequency increased, they came to our hospital for further evaluation.
Your thoughts about this patient's complaints? So suppose if you are sitting in there in the ER or you are seeing the patient for the first time. So what are your thoughts about this patient's problem?
Sir, from this history, I came to know a child has already a history of global developmental delay. And this child also gives a history of regression of milestones. From
Okay,
past history, I have noticed.
not like that, not like that. You know that there is, they have told you the history. There's, sir, this child is not normal. Now suddenly this child started having this type of moments. Then on hearing this history, so what are your thoughts about this patient's problem? Is it abnormal movement or something else?
So it could be epileptic spasms.
So you think that most probably it is a seizure disorder. And the
Yes, sir.
nature of the seizure, what do you think?
I think they can be epileptic spasms, sir.
Spasms. So when is, what do you mean by spasm? What is the nature of the seizure? Did you imitate the seizure, or they have shown a video of the seizure, or this abnormal movements, or the whether you have seen personally?
Yes, sir. I have seen the spasms personally, and they were sudden flexion movement of neck associated with flexion of all four limbs. Sir.
You saw it
Lasted
personally.
for about
Ah.
10 seconds.
You saw these moments personally,
of
and
course-
your impression about this moment is abnormal movement is. Hello, Alvin.
Yes, sir.
Somebody's phone is. Others are, please mute your phones. There is background noise. Hello, Alvin.
Yes, sir.
Your description or your thoughts about this patient's problem. Is it a, you said it's a seizure and you said spasm, infantile spasm you are thinking. Hello, Alvin,
Yes, sir. I can hear you. Sir.
scientifically, which type of seizure you are thinking? Medically,
Infantile spasms.
what are the other types of spasm that can happen in a newborn baby or an infant? Is it a,
There can be jitteriness or there can be myoclonic jerks.
I think, is it a myoclonic jerk?
Sir,
Is it a myoclonic jerk or a generalized tonic-clonic seizure or a something?
sir, usually in myoclonic jerk, upper limb and head.
This one. Or a tonic spasm, or a myoclonic seizure, or a generalized tonic.
I felt it was a tonic flexion type spasm, sir.
You are thinking terms of tonic flexion type of spasm, most probably myoclonic seizure.
Yes.
Okay, proceed. Then, so then you yourself saw the these abnormal movements, and then what happened?
Sir.
Then what
So
happened to
can
the
I-
patient? Then what happened to the child?
So, sir, can I go back to past history or?
Okay, I can you go by the past history, no problem.
So I'd
No
like
other
to
events,
start.
no other events. You are told there are no pointer symptoms suggestive of involvement of any of the system. Only abnormal thing that you notice, that's abnormal spasm movements that's coming in clusters.
Yes, sir.
Okay, proceed. So your thought at this level is that child is having myoclonic seizures. Isn't like that?
Yes, sir.
Okay.
And since child has developmental delay, I would like to start my history from antenatal history.
Okay.
This baby was only a baby of non-consanguineous marriage. There was no prior history of any abortions with mother, and he was spontaneously conceived at 28 years of maternal age. And preconceptional folic acid was not taken, and folic acid was started after pregnancy was confirmed by UPT test at around 5 months, and regular antenatal checkups were done. She's a
So
good
why
case.
you
And,
mentioned that preconceptional folic acid was not taken? What is the relevance?
Sir, any neural tube defect, there can be.
If you want to give preconceptional folic acid, what's the dose of folic acid that you will advise?
Preconceptional folic acid dose 400 micro.
Correct answer. Okay, 400 microgram. Okay, so you are giving folic acid prior to consumption to prevent, and there's no NTD. Okay, proceed.
Sir,
Folic acid is standard.
And there was no history of fever with rashes, unsupervised drug intake, or radiation exposure during
Which
first
condition
trimester.
you are trying
There's
to
no-
exclude? Which Alvin, which condition you are trying to exclude when you say that there is fever with rashes?
Sir, any torch infections or
Which torch infection
cytomegalovirus
specifically, which
infections
torch,
during
that's a generalized term. Which infection you specifically?
cytomegalovirus, sir,
No, sir.
and rubella?
Rubella. So, Alvin, can you get rubella even without rash in an adult?
Yes.
Yes, okay. Fever with or without rash is very important. So anything,
Yes.
any fever in the first trimester is very significant. So what's the clinical manifestation of rubella in an adult? I said a rash is said. Other than that, any other specific finding? Any lymphadenopathy, if it all occurs in which part of the body that occurs?
Yes, sir.
Any lymphadenopathy is pathognomonic of this problem, this condition, rubella in an adult. Any idea?
Sir, occipital.
Posterior,
Occipital lymphadenopathy.
correct, posterior cervical lymphadenopathy. Do you know the enanthem that is seen in rubella?
Sir, I couldn't hear.
Enanthem. What is the enanthem that is in measles? Alvin, are you there?
Yes, sir.
What is the enanthem that is seen in measles?
Oblique spots.
Correct. What is the enanthem in rubella?
In rubella, Forshamer spots.
Correct answer. So, okay, that's a different story. So, fever with or without rash is very important. Unsupervised drug intake, then radiation exposure. Then, anything else you would like to ask in the first trimester other than that?
Was there any history of
Bleeding or spotting.
bleeding?
That's also very important. That is nature's way to abort if there is abnormality in the fetus or embryo. Nature tries to abort that. So that's a manifestation of this bleeding or spotting. Then you asked about the hyperemesis. What is the genetic wisdom of hyperemesis gravidarum in a pregnant woman?
Sir, I couldn't hear you. Sorry.
Genetic wisdom. Why do they vomit and continuously in the first trimester?
Sir, in
Okay.
for
So, is glucose is good in the first trimester? Excessive glucose?
no, sir.
Why? Hyperglycemia is a teratogen. Hyperglycemia is a teratogen.
Correct. Yes.
Okay, proceed. What is a Binukutan? What is this? It's a PG clinical discussion. Okay. Proceed. So then, antenatal check book hospital, private hospital, no history of rashes. Proceed. Then proceed.
So coming to second trimester,
I want to know, before that, I want to know paternal medical history. Did you ask about the paternal medical history?
yes, sir. Father is there is no history of diabetes or asthma or seizure disorder in father. He is aged 34
So I am
years.
not bothered about so paternal diabetes may not cause problem, but paternal tuberculosis, so paternal tuberculosis can cause infection to the mother. Paternal HIV can cause problem. Paternal syphilis can cause problem. So
There is
like
no
that you have to ask.
There is no
You have
history
not
of
mentioned about
tuberculosis
paternal
in
medical
father.
history. Have you mentioned about paternal medical history? No, you have not mentioned that.
No, sir.
That's also very important. Okay. Not only medical. So mother was otherwise normal prior to the conception. Isn't it like that?
Yes, sir. Baby.
Okay, proceed.
And coming
Second
to second trimester, kicking was felt at 18 weeks. Anomaly scan was said to be normal. Mother was started on iron, calcium, and folic acid was continued. 2 doses of injection TT was taken. There was no history of raised blood sugars or raised
Alvin,
BP.
1 second. I want to know what is the best vaccine can be given to a pregnant woman? Is it TD or something else? Whether if they can afford, which vaccine you would like to give to the pregnant woman? At least one dose.
TD only, sir. TDAP.
TDAP. What is the trade name? I don't want to say the trade name, but you can say Bustrix or something like that. Okay, then no history. GDM, PAH, hypothyroidism. Okay, proceed. Then
And there was no history of any bleeding or leaking QE during second trimester.
two more things are very important that you have to ask in the second trimester are whether this mother was screened against infections. So which all infections you would like to screen during second trimester?
Sir, syphilis,
Okay. Syphilis,
HIV,
they don't use
syphilis.
pre-op serology. What are the tests that you do in pre-op serology?
Sir, syphilis, HIV, and HPSAG.
Hepatitis C also.
Hepatitis B, sir. Sorry, sir.
Hepatitis C, HIV, hepatitis B, hepatitis C, and if you want, you can do the for this VDRL also. Okay, then proceed. Then you didn't mention about intake of extra calories and proteins during pregnancy. That is not important?
Sir, mother had adequate weight gain during second trimester.
No. You have to be very specific that mother has to take how much calories. What is WHO recommendation of intake of extra calories during second and third trimester?
670.
No,
500
that's for elephants. Or somebody saying that you have to consider the weight gain also. 350 calories and 15 grams of protein during pregnancy. Tell me a simple diet that gives 350 calories and 15 grams of protein. What is the nutritive value of 1 glass of milk, Alvin?
So 1 glass of milk gives 130 kilocalories and is it cow's milk or?
What is the milk that usually give? Cow's milk or
Sir,
heart's milk?
130 kilocalories and 6 grams of protein.
6 grams of protein and 2 glasses of milk. That means around 257 plus 12 grams protein. So 2 glasses of milk and 1 egg, suppose the mother takes during second trimester, that will correct the nutrient deficiency. Proceed. That also you have to advise. Third trimester.
So, third trimester, mother continued to pursue good fetal movements, and internal growth scans were said to be normal. There was no history of any antepartum hemorrhage, pregnancy, raised blood pressures, or any abnormalities in any oligohydramnios and polyhydramnios was not there. There was no history of raised blood sugars, and there was no history of any fever during third trimester.
When do you say the mother is having polyhydramnios?
When a single deepest pocket measures more than 9 centimeters or single deepest pocket more than 8 centimeters and liquor is more than 25.
Correct answer. Okay, proceed. Then proceed.
And coming to natal history, baby was delivered by term normal vaginal delivery with a birth weight of 2.8 kg. And baby cried soon after birth, but was noticed to have respiratory distress in the form of fast breathing, and was immediately shifted to NICU and was started on oxygen support by hood.
Your thoughts,
And,
your thoughts at this level, you said baby is having respiratory distress. What are the cause of respiratory distress in a normal vaginal delivery? The time baby, normal vaginal delivery, then suddenly baby is having distress. What are the possibilities that you consider at this level? Suppose if you are in the labor room or you are involved.
can be congenital. It can be due to upper airway obstruction, or it can be due to any sepsis like congenital pneumonia. Or if there is
Any
any
history
aspiration,
suggests
or it can be,
why do you want to bring sepsis in this patient? Any historical point suggest your sepsis for this
No, sir.
mother? Eh?
no, sir, there was no.
When will you suspect newborn sepsis? In the
If
historically.
there is any late,
Yes,
third
correct.
trimester fever or urinary tract infection, or if there is foul smelling liquor,
Yes, correct. Maternal high fever, PRI more than how many hours?
more than 18 hours.
Okay, then anything else?
Sir,
Uterine tenderness, evidence of
Yeah, yes, sir.
chorioamnitis. So any history like that for this mother?
no, sir, no. No
Any
history
unclean
suggestive of-
vaginal examination more than 3 times? Nothing.
No,
So
sir.
then what are the causes of other than sepsis? Which are the possibility you will consider? If the
There
baby is
can
having
be
distress?
transient acne of newborn, which is
is it normal vaginal delivery?
No, sir. Usually more common in LSCs. Male
Okay.
babies born by.
This case, pardon me, the cause of respiratory distress. What are your thoughts?
It can be. Sir, it can be due to upper airway obstruction, sir. Upper airway obstruction, if there is any secretions or if there is coil lateration or nasal
No, your
stenosis.
private secretions you will immediately clear. So then
Yes, sir.
otherwise,
And then coil lateration or nasal stenosis.
so
If there is any cleft lip or
retrospectively, do you
cleft
think
palate.
that it's due to coil atresia?
Sir,
Tell me other causes of breathlessness in a newborn baby. Was it are you sure that the baby was tame baby?
yes, a term baby.
Tame baby only. Then other causes that you suspect, suppose if you are in the treating postgraduate.
So if there is any cardiac diseases like or any chest wall deformities,
Chest wall deformities agreed. Then
or if there is hypoglycemia or
that baby develop hypoglycemia immediately after birth.
no, in this case, no, sir. In this case, mother was not diabetic. Otherwise,
What are the causes of breathlessness in a newborn baby immediately after birth? So if it was a LSCS baby, could have think that's a TTNB. But this case, in preterm babies, there are causes like a HMD.
this can,
And
yes,
then other causes. But antenatal scans.
congenital diaphragmatic hernia.
But you said nowadays that was a STERIA story. Nowadays,
Yes, sir. Now in an
diagnosis of CVD,
anomaly scan.
anomaly scan they used to pick up.
Yes, sir.
Any chance for spontaneous pneumothorax?
Yes, sir.
How will you rule out that? If there is breathlessness, what will you do? Immediately,
Air entry.
clinically you can, but definite investigation.
Chest X-ray.
You take an chest X-ray and then see whether there is any spontaneous pneumothorax for the patient. Anyway, what happened is baby was put to the shift to necessary and B was put on oxygen support. What do you mean by that? What type of
By
oxygen support?
O2 by hood, sir.
Then the child improved.
Yes, sir. Child improved and O2 support was being after on day 2 of life.
What was the feed on day 1?
Child was continued on. Child was started on IV fluids.
Okay, then.
And routine blood investigations were sent.
Then urine and meconium pass within 24 hours. So which
Yes,
one is
sir.
more important? Passing meconium or passing urine, which is important?
Passing meconium in first 24 hours is important, sir.
More important than passing urine. Invariably, all babies will pass urine. Even if babies having severe PUV, they will pass urine. Okay. What are the conditions that is suspect if there is delay in passing meconium? Alvin.
Congenital hypothyroidism.
Hypothyroidism.
Hirschsprung's.
Springs.
Cystic fibrosis.
TF.
Sir, then
Commonest.
ARM, sir.
ARM. Okay. Then, and then you said, then what is the next thing that happens?
Sir, after that, there was a history of neonatal hyperbilirubinemia on
Why
day
this
4
baby,
of
what is the
life.
group of the mother and what is the group of the baby?
Blood group of mother was A positive and baby blood group was B positive. There was no
What might be the
improvement.
cause of this jaundice in newborn baby? If non-A/non-B incompatibility, what are the causes?
Poor feeding
Okay.
and if
Because they were start on breastfeeds, but so whether you said the baby was on parallel fluids or on artificial feeding during first 24 hours?
they said he was on IV fluids, sir.
IV fluids only. Okay, then baby was fed only on off 24 hours only. So poor feeding. Second cause. What are the causes?
Causes of hemolytic anemia like hereditary spherocytosis or G6PD
Oh, you want to say
deficiency.
that? Yeah, retrospectively, do you think that baby is having hereditary spherocytosis?
Sir, cephalometoma can also be a cause of.
In his in history cephalometoma, you have to look for cephalometoma. Other than cephalometoma, what are the source of other bleed that can happen in a baby?
Subdural.
Subdural.
Sorry, sir. Subgaleal hemorrhage.
Subgaleal, then subcapsular hematoma of the liver, adrenal hemorrhage, It can also happen. Okay. So there maybe this also any other cause of bleeding. If this baby passed meconium within 24 hours, then that is not a cause of the jaundice. Okay, then proceed. So any chance for hypothyroidism? Historically?
Yes.
No, historically,
No,
no chance for hypothyroidism. Okay.
and there was no history of seizures or hypoglycemia in neonatal period. Thyroid function tests were done before discharge and was normal. OAE done was normal, and baby was discharged on day 7 of life. And umbilical cord fell on day 10 of life. Sir.
If there is delay in falling umbilical cord, which condition you will suspect?
Sir, factor 13 deficiency. Sir, sepsis and factor 13 deficiency.
Sepsis is there. Other than that, any other condition that can cause delayed falling? in the-
Leukocyte.
Yes, LAD, correct answer.
Yes.
So baby was discharged on 7th day of life. Why this much delay? Because of respiratory distress.
Sir, 4th day he was found to be sick, and phototherapy was given for
Of course,
1 day.
phototherapy.
And
So at that time, baby was feeding well, passed urine motion, baby was otherwise active. Okay,
Yes.
no other significant problem. So that means, okay, then proceed. Then what happened? Then what happened to the baby?
Then by 3 months of age,
So after 7th day, by 3 months, there was no other problem. Baby was sucking normally.
baby was feeding well. Baby was suck-
Yeah, I want to know
baby
whether
was
baby was gaining weight. So they,
Yes,
yeah.
on routine follow-up, mother gave history of adequate weight gain.
Okay.
Sir, according to baby's birth weight, sir.
Pardon?
As per baby's birth weight, mother gave history of adequate birth weight, adequate gain of weight during subsequent follow-up visits, sir.
May I ask a simple question?
Yes, sir.
What is the weight gain that you expect for a 20? What is the weight of the baby at birth?
2.8
22.9
kg, sir.
What is the weight that you expect for this baby on 20th day?
On 20th days, first 10 days, I expect there would be loss of weight for about 10%, and then on subsequent days, 20 to 30 gram weight gain would be there.
That means what is the weight for this baby that you expect on the 20th day?
Almost 2.8.
Hmm?
So 3.2 kg.
3.2, correct answer. Okay, proceed. Proceed.
And baby started pooing by 3 months
That
of age.
means 7 months to 7 days to 3 months, there was no other significant events for this baby. Start
No, sir.
by 3 months of age. Then
And he attained head control by around 4 months of age. And mother also gives history of attempted rollover by 4 months of age. But social baby did not attain social smile. And
baby
at
didn't
4
attain
and a-
social smile. At what is baby supposed to attain social smile?
at 2 months of age, baby was supposed to attain social smile. But
Is it an important
even by-
milestone? What is the relevance? What is the significance of social smile? What do you mean by social smile?
on baby smiles. Sir, vision can be a
What do you mean by social smile?
sir, a baby on seeing anyone, a baby smiles.
Anyone? Usually mother. Usually no, not
Usually,
anyone. Usually see the baby is in contact with the mother continuously. That baby will
Smiling.
smile back, smiles back to
Yes.
you. So what is the afferent pathway? What is the efferent pathway?
Sir, afferent pathway is cranial nerve. Sir, afferent pathway is optic nerve, and efferent pathway is cranial nerve. Sir.
Which cranial nerve?
So 7th cranial nerve.
Only 7 cranial nerve is involved in social smile.
Sir,
Only 7th cranial nerve is involved in social smile.
2nd cranial nerve and 7th cranial nerve, sir.
No. So when people smile, you look at me. When I smile, there is an emotional element. Isn't like that. So
5th
which
cranial
system
nerve, sir.
is concerned
Cranial
with-
nerve 5 is also involved.
No man. whether any other animals or any other living things are able to smile. Any other living things are able to smile. So which center is associated with the smile?
Hippocampus.
Limbic system. Is it like that? So that's present only in human beings. If baby smiles back to you, you can reassure the parents that this baby is going to be normal. Baby is able to smile on which day? Maximum is 8 weeks. So this baby didn't have a social smile. So that's a very, very serious thing. So at that, they didn't consult anybody when baby didn't have a social smile. Did they consult?
No, sir.
Why didn't they consult? Are they not aware or nobody has told them about that? Oh, we couldn't chirikinellalo and the parnille our article.
Sir, their first consultation was at 4.5 months.
Why? No, not like that. I won't believe, because in this country, you know that you are giving first consultation at 6 weeks of age for anybody, even for poor people. They used to
No, I mean to say for developmental delays.
Development delay, not for that. First consultation is 6 weeks of age.
First consultation was at
First consultation
they,
was where was the
routine
delivery
follow-up
conducted?
was there, sir, at
Which
2
hospital
weeks,
was
and
delivery
then for
conducted?
vaccination they have gone
No,
at 6 weeks.
which hospital delivery was conducted? Which hospital? Gone.
Sir,
Government, which hospital delivery was conducted? The government
it was
hospital?
a no, sir, it was a private hospital.
Then they definitely they will ask the mother to come back.
Yes,
No,
sir, they had come,
baby is
they had
gaining
followed
fever
up
or
at 2 weeks.
Hmm?
They had followed up at 2 weeks at the private hospital, and following that they went for immunization in a government hospital, sir, from 6th week onwards.
Okay, 6 weeks I agreed, but then they come for 10th week. Didn't they tell that baby is not having any social smile?
So at 10 weeks, mother was not aware of this.
Mother may not be aware, but the other relatives, grandparents and neighbors may be aware. അവരെല്ലാം ചോദിക്കും ഈ കുഞ്ഞ് ചിരിച്ചില്ലല്ലോ, മുഖത്ത് നോക്കി ചിരിച്ചില്ലല്ലോ എന്ന് പറയാ. എല്ലാവർക്കും അറിയാം ഇത് ചിരിക്കണം എന്നല്ല. എന്നെ 56 ആകുമ്പോൾ പിള്ളേർ ചിരിക്കണം എന്ന് എല്ലാവർക്കും അറിയാവുന്ന കാര്യമാണ്. Okay, but in this case anyway, so that's an important thing in the natural history of this patient, and they didn't bother or they ignored. Anyway, then what happened?
Sir, at 4.5 months of age, baby developed severe pneumonia, and which required ICU admission and was and also required HFNC support.
What may be the reason for this pneumonia? You know that pneumonia is not common in children less than 6 months of age, because this baby is not exclusively breastfeed.
Yes, sir.
It is receiving adequate amount of antibodies. What may be the reason for this pneumonia in this baby at this point of time? Any other significant problem? You said no delay in passing meconium and no delay in following this umbilical cord. What may be the reason for that? For pneumonia for baby at the age of 4.5 months? Is it an infection, viral infection, whether anybody in the neighborhood or anybody in the house had any infection?
So there was a history of contact with fever.
People having fever. So most probably, do you think this is a bacterial infection or a viral infection for baby at that time? Any other? Any idea?
Sir, probably a viral infection.
Baby was investigated at that time. Baby was put on HFNC support. That's what you say.
Baby was on HFNC support.
How many days baby was in the hospital?
Sir, this admission baby was there for 6 days, sir.
Somebody is asking, why can't that be a case of bronchiolitis? Yes. What is your comment? It can be bronchiolitis or some other virus infection. Okay, proceed then.
And sir, it was during this admission, child was evaluated for global developmental delay, and mother also.
So this baby is having no social smile, and then they saw not that baby is having regression of milestone. What do you mean by regression of milestones? What do you mean by that? Whether the baby is having any milestone?
Following this admission, following this infection, mother gives history that even attempt to roll over was not there, and his head control was also deteriorating, sir.
But you're quite sure that the baby didn't have any birth asphyxia. Baby cried immediately after birth.
Yes, sir.
Okay, but this they have noticed that your thoughts, because if there that such a history is not there, is baby is having social smile, and then baby had normal development delay, baby was able to turn over, and baby when baby develops infection, is regression is accepted, temporary regression is accepted or not?
following an acute
temporary regression is accepted if the baby is having severe infection. So that is well accepted. But in this
infections.
case, it may be different in the sense that this baby didn't have any social smile. This baby, then babies have no milestones, proper milestones. So, and then this maybe may not be that significant. Like a normal case. Normal case, you want normal case temporal regression is acceptable, but in this case, it may be
Following
significant. Significant. You proceed. Then what happens?
So then baby started developing abnormal movements in the form of flexion of neck and flexion of limbs in clusters, which were lasting for 10 to 15 seconds, 2 to 3 times per day since 10 days prior to admission. 10 days prior to this admission, and the number of spasms increased in frequency and intensity since last 3 to 4 since the prior 3 to 4 days.
Okay, proceed. So before examining the patient in detail, what are the points that you consider historically for this patient? Now it's time for you to examine the patient. Is it like that? I know that you have to go to the dietetic history, immunization history, etc. But before you proceed, what are your thoughts about this patient's problem, this child's problem?
So now this child has presented with global developmental delay with developmental regression. And there is also
regression. I won't give much importance because this child regression occurred when the child had a severe infection.
Yes, sir. And there was a child also, a baby also developed seizure disorder in the form of epileptic spasms.
So most important thing is development delay is there. Over and above that, this child started to have continuous flexor spasms, myoclonic seizures. Your thoughts about this patient's problem? What are your thoughts at this level? What may be the cause for this patient's problem?
So it can be any epileptic encephalopathies.
Epileptic encephalopathy, but usually we consider congenital traumatic neoplastic inflammatory. Suppose if you think in like that, your thoughts. Is it an infection? Commonest, is it a meningitis? Is the cause for this patient's problem? Do you think the cause of the seizure is meningitis?
No, sir. There was
no, sir. Because because this child is fully vaccinated and they have taken vaccinations. Have they taken vaccination?
Yes, sir. They have
taken vaccinations. No fever, no other particular, no otitis media, nothing like that. So infections are unlikely, and especially bacterial infections are unlikely. Then viral meningitis is a remote possibility. Anyway, but there is no fever for this patient, so infection is unlikely. Then what may be the cause? Trauma.
So there is no history of trauma for this patient.
There is no history of trauma. Then what? Neoplasm is. Do you think there's a cause of neoplasm is the cause for the seizure and development delay?
No, sir.
Neoplasm.
There is no history of any vomiting or.
Neoplasms are not common. Then what may be the cause of this patient's problem? Can be due to some other causes? Seizure.
Yes, sir. It can be due to any structural abnormalities, or it can be due to epileptic encephalopathies, or
structural abnormalities, epileptic syndrome. Then any chance for a neurocotinous? Any chance for neurocotinous? So 1 second, Alvin, our president is calling. Ramesh, PG class. Yes. Any other cause for seizure in a child other than this?
So then neurodegenerative diseases.
Before you go to simple inborn error of metabolism.
Yes, sir. Inborn errors of
metabolism that you suspect.
Sir, in this baby.
Somebody is telling the answers. Inborn error of metabolism can be due to hypoglycemia or other inborn error of metabolism. I would think like that. So all patients have to consider then that somebody has that neurocotinous syndrome. Is that a possibility?
Tuberous sclerosis.
Yes, is a possibility. Neurocotinous syndrome like tuberous sclerosis. Okay, then any other neurocotinous syndrome that you know? Alvin,
Sir,
any other recording syndrome that
Ataxia telangiectasia.
ataxia telangiectasia? What is that? What is the clinical manifestation of ataxia
Sir,
telangiectasia?
sorry, sir. Neurofibromatosis.
No, you say what is the clinical manifestation of ataxia telangiectasia?
Sir, developmental delay, ataxia, and
Where do you see telangiectasia? Where do you see telangiectasia? Which part of the body?
sir, eyes.
Eye. Okay.
Sir, did you ask about which part of the body telangiectasia is seen?
Pardon?
Sir, did you ask about which part of the body telangiectasia?
Yeah. That's yeah. You said the answer. Eye. Correct.
Ah,
Okay. Then, so neurocortical syndrome that you are suspect, inborn order of metabolism, you have to suspect. Don't you want to suspect dyslipidemia, hyponatremia, hypocalcemia, hypoglycemia, hypomagnesemia, hypernatremia?
Yes, sir.
But there are no other, but there is no historical points to suggest this dyslipidemia. Then, can we do it to hypertensive encephalopathy? This child is any chance for hypertensive encephalopathy?
Sir, no.
Whether hypertension can present as a seizure?
Yes, sir. It can present as a
Yes.
seizure, but
So it's very important that you have to take BP of all children. Isn't like that? At
Yes.
least teaching hospital, you have to take the BP of all children. So in government hospitals may not be possible because of the heavy rush, but at least in primary health centers. But in teaching hospitals, you have to take the BP of all children at least once. Ideally, you have to take 4-lib BP if not
yes,
possible.
sir. BP was taken for this cell, sir.
Okay, proceed.
BP was
So your thoughts about these patients at this level. So retrospectively, you think there are no neurocortical markers. Then what are your thoughts about this patient's problem? Global development delay is there. Then seizures occurred. Then any tuberous sclerosis is a possibility.
there is no neurocutaneous markers for this cell, sir.
But seeing these white patches may be difficult, especially if this child is fair skinned. So you have to look very carefully, then you may see. Okay. Anyway, I am thinking like that because this you said child is having myoclonic seizures. Isn't like that? So neurocortical syndrome is an important possibility for this patient. You have to think. And then other possibility, so these are the various possibilities you have to consider at this level. Then you proceed. Proceed.
Now, sir, coming to developmental history, under gross motor domain, mother gives history of attaining head control at 4 months of age and attempted rollover also by 4 to 5 months of age. But following this infection, mother gives history of loss of head control. And in fine motor domain, there is no palmar grasp, but baby is holding hands open. And in language domain, cooing was attained by 3 months of age, but baby does not laugh aloud. And under social and adaptive domain, baby has not attained social smile. And mother also gives history of baby not following bright objects.
So vision is correct. Is vision correct?
Yes,
Vision
sir.
and hearing. Vision and hearing.
Vision, vision, baby does not follow bright objects, and hearing was normal, sir. Baby responds to sound.
You said child is able to make noises, coos like that, but baby is not following mother. Not following.
No, not following, sir.
Okay. So it means the vision, you are suspicious about the vision of this child.
Yes, sir.
So is that is the reason for this lack of social
No
smile?
social smile could be, sir.
Okay.
In this state.
Proceed. Proceed.
Sir, and coming
Vision
to
and hearing. Have you included vision and hearing in the history?
yes, sir.
Yeah. I would say this. So what are the things that you check in the gross motor, fine motor, language, social, adaptive,
Social and
vision, and hearing.
adaptive and
So
vision
all
and
these
hearing
things
also
together.
should have been included.
But you are not included that in the history. That you have to include in the history. Gross
Yes.
motor, fine motor, language, social, adaptive, and also you have to calculate the quotient. So when you present a case,
Portions were calculated in developmental assessment part.
For
Portions were
development
for
assessment part, yeah. Okay, oh, fine, okay. Then proceed.
And coming to diet history, sir, babies on exclusive breastfeed and all calorie and energy requirements are met by breast milk. Baby is fed for about 10 to 11 times a day. Mother feeds baby for about 15 to 20 minutes each time, and there is no history of any difficulty in sucking or difficulty in swallowing. And the mother gives mother says that she has adequate breast milk. She gives history of letdowns.
Okay, suppose in
And,
normal cases, how long will you advise breastfeeding to a baby? Normal
Sir,
children.
Exclusive breastfeeding should be continued for at least 6 months.
Then
Breastfeeding should be continued at least till 2 years. With
okay, you start semi-solids at 7th month of age. Proceed.
yes.
Proceed.
Sir, coming to immunization history, baby is completely immunized for age. BCG scar was present. Baby received BCG, OPV, and hepatitis B at birth. And at 6 weeks, OPV, IPV, pentavalent vaccine, rotaviral vaccine, and PCV was administered. At 10 weeks, OPV, second dose, pentavalent, and rotaviral vaccines were administered. And at 3.5 months, OPV, IPV, pentavalent vaccine, rotaviral vaccine, and pneumococcal vaccine second dose was administered.
Proceed. Proceed.
And coming to family history, he's only child of non-consanguineous marriage, who was spontaneously conceived at 28 years of maternal age. There is no history of any seizures or intellectual disability in family, and there is no history of any unexplained death in family.
Proceed.
And coming to socio-economic status, they belong to modified Kuppuswamy class.
That's not relevant in this case. Skip.
Okay. So coming to summary, after history, this 5.5-month-old boy baby, who is the only child of non-consanguineous marriage with an uneventful antenatal period, was born by term normal gene delivery, and baby had respiratory distress soon after birth and required ICU admission for 1 day, and baby was also noticed to have neonatal hyperbilirubinemia at day 4 of life, for which baby was given phototherapy for 1 day. Baby was noticed to have delay in attaining developmental milestones, as baby did not attain social smile by 2 months of age, and there was also a history of delay in attaining gross motor and fine motor milestones. And this baby had bronchopneumonia at 4 months of age, requiring PICU admission and required HFNC support. And following this, baby was noticed to have regression of developmental milestones, and now baby presented with epileptic spasms since 10 days prior to admission.
May I please proceed? Proceed. Go to the examination finding.
So coming to general examination, baby was conscious, alert, active, and was lying in supine position. And coming to pulse rate, pulse rate was 102 beats per minute, regular in rhythm, normal in volume, and was felt in all peripheral vessels. And there was no radial or radiofemoral delay. Respiratory rate was 46 cycles per minute. And BP was 90/60 millimeter of mercury in right upper limb, measured in supine position. And baby was afebrile, and baby was maintaining saturation at room air. Peripheries were warm, and peripheral pulsations were well felt. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema.
Proceed.
And
Proceed.
coming to head-to-foot examination. Head appeared normal in size and shape. Anterior fontanelle was open, measuring 4 centimeters. Posterior fontanelle was closed. Hair appears normal. Baby was noticed to have facial dysmorphism in the form of prominent forehead, bilateral hollowing, hypertelorism, and loss of
Any
ears.
cataract? Any cataract?
No, sir, no cataract. There is no cataract. There is no cataract. There is no any rings noticed in eyes. And baby also was noticed to have a short nose with upturned nares, and there was thick upper limbs.
So You said, 1 second, you said baby is having velocities. How
Yes,
do you
sir.
measure this for this velocity?
How?
How will you look for this velocities?
Sir, a line drawn from medial canthus to sir, a
Hmm.
transverse line is drawn from medial canthus to and if the one third of year is over this, it is said to be normal. And
So
if it
you
is
make an X-ray film with a T-shaped X-ray film, and then you light and draw, and then should pass through this inner candy, and then you measure. Okay, agreed. Okay, agreed. One touch be above. Proceed. So this baby is having velocities. Then short nose with upturned ears. Any slant up normality?
no, sir, there is no Mongolian slant.
No. Upward
There
slant.
is no
Upward slant. Any upward slant or downward
no, sir,
slant?
no upward slant.
No upward
Noted,
slant.
sir.
Okay, then. But you said thick lips were upper lips. Eyes are normal. There is no any other corneal abnormality. Any corneal abnormality?
No, sir, no corneal abnormalities were noted.
Okay, proceed.
And oral cavity was normal. Chest and abdomen was normal, and limbs were normal. Baby had a spine was normal. Baby had normal male external genitalia. Bilateral testis was descended, and there were no neurocutaneous markers. And BCG scar was present.
No, you look specifically for neurocutaneous markers, but there are no. What are the neurocutaneous markers that you specifically look?
Shangreen patches
Where do you look for shagreen patches?
on back of the baby. Sir.
Pardon?
On back of the baby.
Back of the baby means in a trunk or any chair, trunk or lumbar region or any other site. Specifically, usually which area you see the
In
what
lumbar
is
region.
not lumbar or the buttocks. What is the typical description of shagreen patch?
So, shangreen patches are rough with orange peel consistency, sir.
Velvet leathery consistency. And then any other thing that you look? What is the typical macule that you see in tuberous sclerosis?
Ash leaf macules.
Correct answer. And then what is the clinical manifestation of this other one? Neurocutaneous syndrome, von Reckling-Hertz's disease.
Sir, pardon me.
What is the other neurocutaneous syndrome that you know? Neurofibromatosis.
Neurofibromatosis.
What is the neurocutaneous marker in neurofibromatosis?
Sir, Caféolé spots and neurofibromas.
Spots. And then what is the neurocutaneous marker that you see in Sturge-Weber syndrome?
Sir, in port vein staining, sir.
Okay. Then which part of the body that you see?
Around eyes.
Eh?
Sir, in unilaterally in around eyes and like distribution of trigeminal nerve areas, sir. In face.
Yeah, okay. Now, which division? Ophthalmic division of the trigeminal nerve. Okay, then what are the then what is the you are told me about this ataxia telangiectasia. Okay, proceed. So you look for the neurocutaneous markers, but there are no neurocutaneous markers. Okay, then wait.
So coming to anthropometry, child's anthropometry was compared with WHO growth charts. And weight of this child was 5.6 kg against expected of 7.6 kg, which falls below.
What is the birth weight of the baby?
2.8 kg, sir.
2.8 kg. But now baby is.
It has doubled by 5 months.
Then now it's only 5.5 months.
Sir.
Now it's only 5.5 months.
Yes, sir.
And why do you want to expect 7.6 kg for this baby?
Sir, according to WHO growth charts, sir.
WHO, but normally that birth rate doubles by 5 months only. So don't be you should not have over expectation for a baby. You said breast milk is adequate, and there is the milk is flowing from the other side like that you're told. Okay, then and length.
The length of the baby is 59.5 centimeters against an expected length of 67 centimeters. which was below -3 standard deviation. But weight for length of this baby was normal, falling between 0 to -1 standard deviation, and there was no microcephaly. Head circumference was 41 centimeters against an expected of 43 centimeters.
So, is there a microcephaly?
No, sir, there was no microcephaly. It falls between -1 to -2 standard deviations.
Have you applied Dyne's formula?
Sir,
Have you applied Dyne's formula? What is Dyne's formula?
for head circumference, sir,
What is Dyne's formula?
length from head circumference.
What is the formula?
Sir, length by 2 plus 9.5
You will
plus
get
or
the
minus 2
50th centile.
plus
You will get the
Yes.
50th centile. So length
Yes,
by
sir.
2 plus 9.5. Length is 59.5. Half of that
Yes,
is of
about
that is-
29.75,
29.5 plus 9.5.
49.5 plus or minus 2.5.
29.5 plus 9.5.
Sir, 39.5.
38 point. 29, 38, 39 plus 2.
Sir, 41.5. Sir.
41.5. So that is towards 95th centile. Isn't like that? Huh? So this is towards 95th centile. Above 95th centile is considered as macrocephaly. It's large for large for this age. Is it like that?
Yes.
Okay, so this is if the length of the baby is correct that you have mentioned, so it's towards the 95th centile,
Yes.
and the frontal eye is also 4x4.
Yes, sir. Only was 4x4 and was open.
So
And
your
it was
measurement as per this standard deviation, I don't think that is relevant in this case, because compared to the length of the baby, the head appears large for this child. If the measurements are correct.
Yes, sir.
So this may be important, this patient, in the context of global development delay. Why? Why it's important? Because head appears
Sir,
large for
some
this.
diseases like Alexander disease and Canavan
No,
disease.
I am not telling about Alexander's or Canavans or something like that, but simple thing.
Hydrocephalus.
Yes, you have to consider hydrocephalus, and for that, a simple investigation can rule out that. What is the simple investigation that will rule out hydrocephalus?
Sir, investigate and
A neurosonogram.
neurosonogram.
So that you have to do. For that is a definite role for this. The measurements are very important. Any other measurement that you have to take for this baby?
Upper limb, lower limb.
Pardon?
Sir.
Have you taken USLS ratio?
Yes, sir. Upper.
Where is it written?
I haven't included it.
Eh?
It's not.
Yes, that's important. When the height is or length is above the normal or below the normal, it's very important that you have to take the. Yes, somebody is saying that AF is also big, right? Correct. Yes, yes. So you have to mention the USLS ratio. So what's the ratio that you expect at 6 months of age?
1.4. 4:1, sir.
No. What is the ratio at birth?
1:1, 1.7.
6 months?
6 months, sir. 1.4:1.
No.
6 months.
1.6:1. Is it like that? Correct answer. Sheila Sani. Okay. 1 year. 1 year. What's the ratio that you expect?
1.35:1.
1 point?
1.3:1. 1.35.
No.
Sir, sorry, sir. 1.5:1 by 1 year.
2 years.
ശൈലാസാനി ഏതാന്ന് വെച്ചിട്ട് അതിന്റെ കുറെ എപ്പിസോഡ് ഹോസ്റ്റലിൽ നിന്ന് എല്ലാ തെണ്ടികളും ഉണ്ട്.
So that means that's very important. This especially when the height is either height or length is increased or decreased, USLS ratio measurements are very important. You can make a diagnosis of so many conditions, like which are conditions you can make a diagnosis by this USLS ratio. Alvin.
Sorry.
Condition that you make a diagnosis by USLS ratio measurements.
Bone defects like achondroplasia.
Correct answer.
And rickets.
Okay. Somebody is telling Marfan, then Klinefelter's, then other syndromes like what? which condition there is a upper segment is more affected, more Q. Okay, so
Error than-
next time you should not be, the height is normal, need not take the USLS ratio. But if the height is decreased or increased, then it's very, height or length is increased. It's very important that you measure the upper segment, lower segment ratio. Oh, somebody is telling, answer is correct. You proceed then.
So then, coming to developmental assessment, gross motor domain, when baby was pulled to sit, there was complete head lag was there. On vertical suspension, there was no scissoring or there was no slip through sign, and on ventral suspension, there was no ragdoll posture, and the head was resting at horizontal plane. And on prone position, there was a head was baby lifted head for momentarily, and developmental quotient was development of this child correspond to 2 months of age, and quotient was 40%.
Whether this child is having normal tone, whether it is hypotonia, or whether it's hypertonia, your comments.
For this baby on inspection, attitude of lips was normal, but
No,
there is
no, man, your assessment, not by
There is,
not patient. You are assessing the patient. Traction response you're doing. I am asking whether after your
mild
assessment,
hypotonia.
hypotonia thinking. Okay, but there is no scissoring, there is no spasm, there is no slip through sign. Then ventral suspension, there is no ragdoll appearance, but in the horizontal line. Okay, there is some, but your thoughts are that baby has some amount of hypotonia. Is it like that?
Yes, sir. On,
Agree. Okay,
I mean,
proceed.
on further examinations.
Proceed.
And coming to fine motor domain, palmar grasp was lost and hands were open, which corresponds to about 8 weeks of development, and developmental quotient was 40%. And baby did not attain social smile, and baby attained cooing was present, and that corresponded to a developmental age of 3 months, and developmental quotient was 60%.
Yes,
And so
proceed.
overall, baby had a developmental age of 2 to 3 months.
Social smile is not at all attained. That means, okay, proceed. Yes.
Now, coming to systemic examination, baby was conscious, alert, and coming to cranial nerve examination, cranial nerve 1 was not tested. Cranial nerve 2,
Baby is able to, baby is able to
olfactory.
breastfeed.
Yes,
Baby is
sir.
able to-
Actually, we could have tested
Alvin,
for
if baby is able to
smell of
breastfeed
breast
that.
milk.
1 second. If baby is able to breastfeed, then most probably cranial nerve 1 may be normal. Baby smells
Yes,
the
sir. Smell
sac.
of breast milk can be present.
The second now,
Second, optic nerve pupils were equal and reactive to light. Direct and consensual reflexes present, and baby was not following right object, and fundus examination was normal.
you examined the fundus.
Yes, sir.
So that's good. You are on your exam or you send the ophthalmologist?
Sir,
Whether have you examined on your own or you have sent the
both-
baby to ophthalmologist?
both was done, sir. Both
Eh?
was done, sir.
Eh?
Both was done. Even we also examined, and ophthalmologist was also,
What are,
also
what are
examined.
things that you expect in this baby? What are things that you look specifically in the fundus of this child?
Any cherry red spots,
Okay,
any chorioretinitis.
or your retinitis, then any optic atrophy. Okay,
Yes,
but
sir.
do you expect papilledema for this child?
No, sir, no.
Do you expect that?
AF was open, and it
Oh,
was no.
correct. Yes, okay, correct. Agreed. Proceed. Then.
And then coming to cranial nerve 3, 4, and 6, extraocular movements were full. Though baby did not follow bright objects, spontaneous movements were present, and there was no ptosis, skin, or nystagmus.
Proceed.
And cranial nerve 5, baby opens mouth normally, and sucking was normal.
Yes. Proceed.
Cranial nerve 7, there was no facial asymmetry. Nasolabial folds were present bilaterally, and there was no deviation of angle of mouth. Cranial nerve 8, baby turns to sound. and cranial nerve 9 and 10, uvula was central, which is visualized during crying, and cranial nerve 11 could not be assessed. And cranial nerve 12, tongue was midline, and there was no tongue passage. Coming to, shall I proceed, sir? Shall I proceed, sir?
Yes, proceed.
Coming to motor system examination, bulk was equal on both sides. There was no visible wasting. And coming to tone, there was a mild hypotonia present in all 4 limbs. On inspection, actually, the attitude of limbs were normal, and there was no flabbiness on palpation, but there was a mild increase in range of movements.
Okay.
And
That's 90. Adductor angle is 90 and pupillary angle is 120.
120 degrees. Elbow reaches the mid-clavicular line on opposite side. And on pull to sit, there was complete head lag. And ventral suspension, there was no scissoring or no slip through sign. On ventral suspension, head rested at horizontal plane. And baby lifted head momentarily when put in prone position.
Okay, proceed.
Now, power was more than 3/5 in all group of muscles in all 4 limbs. Sir.
Next.
And coming to reflexes, superficial reflex, corneal and conjunctival reflexes were not examined. Abdominal reflex was present, and the plantar reflex was bilateral reflex.
Is it easy to elicit abdominal reflex of this child? So in the child of 5 months of age, is it easy?
Sir, it was for this baby.
Okay, proceed. Plantar.
Plantar was bilaterally flexed.
So there is no upgoing plantar.
No, sir.
So there is okay. So you then reflex bicep reflexes DTR.
Reflexes were not exaggerated. They were
Biceps, triceps, supinator, knee jerk, ankle jerk, normal, no clonus.
no, sir. There was no angle clonus or patellar clonus was absent.
Moro is absent, Palmar gasp is absent, ATNR is absent. So that means all the knee ankle reflexes disappeared.
Yes, sir.
Okay, proceed.
And coming to sensory system, baby was consolable on cuddling, by cuddling, and baby cried on IV cannulation. And the sensory system appeared normal, except for vision, as baby was not following bright objects. And cerebellum, there was no nystagmus, but there was mild hypotonia in all 4 limbs. There was no signs of any meningeal irritation, and skull and spine.
How do you assess meningeal irritation in a child of this age group?
Sir, by sensorium.
Correct answer. So this signs like a Kernick sign, neck stiffness, Rudensky signs are not labeled in this age group. Why it's not labeled?
Sir.
So that's a good answer. So that means you are assessed by sensorium rather than by the signs of meningeal irritation. There is no role for this.
My myelination would not be complete.
Not because of that, you know, that the pressure won't build up because of the delayed closure of the anterior frontal lemma.
Yes.
Yes, then skull and shape, skull and spine are normal. There is no other problem. But you didn't measure the USLS ratio. Then you cannot say that skull and spine are normal for this child as you are not measured the USLS ratio. That's a very important thing. So don't skip any of these measurements. You know, for pediatricians, measurements are very, very important. So you should be better than a tailor in measuring things, you know. Otherwise, so many diagnoses can be made by measurements. You know, you have not made the USLS ratio. You cannot say that this child. I don't see the patient, but now you say if you say, oh, this child is saying more Q, then how can you say that I can counter my argument? You cannot. As I said, that child is in a achondroplasia. I am sitting in a faraway place. You cannot argue in front of me that this is suffering from achondroplasia. Already the head size is large and the frontal is large. Anyway, proceed.
Other systems were within normal limits.
Proceed. Respiratory system.
The upper respiratory tract was
Any
normal.
chest, any abnormality in the shape of the chest? No.
No, sir. There
Okay,
was no
then
abnormality in
air entry
shape
is
of chest.
normal.
Air entry was bilaterally equal and chest was clear, sir.
No crackles or wheeze.
No, sir.
Okay, that's important because this child had a breathlessness in the newborn period.
Yes, sir.
Proceed.
And,
CVS.
sir, CVS was also within normal limits. There was no murmurs. And apex beat was felt in left fourth intercostal space at mid-clavicular lines.
Proceed.
And
So,
gastrointestinal
There is no cardiac
system
enlargement.
was
There is no cardiac enlargement.
no, sir, no cardiac enlargement.
That's isn't important. This child.
Yes, sir.
Why?
In
Hypotonia. How will you correlate hypotonia with the cardiac enlargement?
inborn errors of metabolism
Which involved?
and for home-based disease, there can be
Correct answer. Correct answer. Yes. Proceed.
and then gastrointestinal system was
GAT
also,
is very important. GAT in organomegaly.
there was no organomegaly
And both testicles are palpable in the scrotum. Yes, proceed. So after examining the patient, so what are your thoughts about this patient's problem? So you have discussed various things on the history by historical diagnosis. Now, after your examination, what are the other possibilities that you consider? Do you want to offer anything other than that we have discussed in the historical diagnosis? What are the possibilities for this patient? There is no organomegaly, there is no cardiac enlargement, slight hypotonia, global development delay, very few scoring, no cataract. Isn't like that?
yes, sir. So inborn errors of metabolism are less likely.
Because there is no hepatomegaly. Any abnormal smell for the urine or abnormal?
No, sir. There was no abnormal smell noted by mothers.
You are completely excluding IEM. Then
Sir, there is possibility of epileptic encephalopathy.
before that, you consider some other thing. Can be due to
Electrolyte disturbances were ruled out as baby.
can be due to atonic CP.
It can be, sir.
Hmm?
It can be.
What are the points in favor? What are the points against?
There was hypotonia was present.
Reflexes are not very brisk, but reflexes are present. But plantar is you said it
Yes,
is,
plantar was bilaterally flexor.
but that is not very relevant. Okay, then atonic CP is another possibility. Then any other thing? Any chance for intrauterine infections for this child?
Sir, there was no history of any intrauterine history suggestive of intrauterine
Other
infection.
20 points against intrauterine infection.
There is no there is no on examination fundus was normal, no chorioretinized.
No. Before that, what is the birth weight of the baby?
Birth weight is not appropriate for age. Sir.
That means usually in intrauterine infection, what happens to the birth weight?
There is no history of any intrauterine growth restriction.
What happens to the birth weight in most of the intrauterine infections? Most of the babies are intrauterine growth retardation. What is the exception? In which intrauterine infection weight is preserved?
Weight is preserved in syphilis, sir.
Correct answer. Okay, now all other intrauterine infection will be organomegaly, chorioretinitis, then microcephaly are usually present in intrauterine infections, but this baby is not having a microcephaly, but there is macrocephaly, isn't like that? So intrauterine infection is unlikely. So inborn error of metabolism is unlikely. Intrauterine infection is unlikely. And then, which is the possibility? It can be due to neurocutaneous markers.
No new neurocutaneous markers.
But you cannot see any. You didn't see any actually Michael Shagin patches or any capillary spots or any features of Sturge-Weber syndrome for this patient, and no hypomelanosis of it. Nothing is there.
No, sir.
Okay, then proceed, then, but there is obvious findings. What are the obvious? Dysmorphism is present, isn't like that?
Yes, sir. Facial dysmorphism was present.
Like
we
what are
have
the facial
prominent
what
forehead.
is that you saw? Losetius.
Sir?
Losetius.
Sir, there was a prominent forehead was there, bitemporal hollowing was there, and losety ears was present. There was upturned nose and thickened upper lips, and hypertelorism was also present.
One of the most important cause in the birth antenatal history was normal. There is a not regular screening, no polyoligohydramnios. So can we do to HAE is unlikely for this patient historically.
It is unlikely.
Unlikely. So then what else? Can we do to syndromes? Syndromic baby, because
Syndromic. I suspect genetic syndrome to be the primary cause of.
what are points in favor of genetic syndromes for this patient?
So for this patient, mainly epileptic encephalopathy syndromes like West syndrome.
No,
Dravet.
no, you have to say clinically, man. Clinical points in favor of considering syndromes.
Yes, sir. Facial dysmorphism with
Okay, then hypertelorism is present, losety is present. Then what other thing that you saw? You said something in the lips,
yes, sir. Thickened upper lips
and something
and
else.
angulated nails.
Then, but there are no other abnormalities in the hand, in any cleft, no cleft
No,
lip.
sir. The lips were normal.
Okay, then any syndactyly or polydactyly?
No syndactyly, no polydactyly.
Any
There was
abnormal crease?
eyes was normal except for hypertelorism, sir.
Okay, right. Okay, proceed. Then, but there are facial dysmorphism present, so you have to consider as a syndrome for this patient. Then the seizures is the most important clinical problem for this patient and development delay.
Yes, sir.
So now what are your thoughts? Only is a syndrome that produces a recurrent seizures like myoclonic seizures.
Sir,
West syndrome.
West syndrome.
Then any other syndrome? So name syndromes like what are the name syndromes that you know? I know that as a postgraduate student, you are not supposed to say all name syndromes because we able to say the important in which
So
way.
at this stage, usually it can be early infantile epileptic encephalopathies like Ohtahara syndrome. But that usually presents before 3 months of
So you have
age.
to consider various epileptic syndrome like Ohtahara. What is
Ohtahara,
other epileptic syndromes that you know?
Early myoclonic encephalopathy. So then West syndrome, then Dravet syndrome. But Dravet syndrome usually presents by about 6 to 10 months of age. And then if it was a little more elder child, I would have suspected Lennox-Gastaut syndrome.
Before we consider other options, I want to say whether any chance for neuroregression, neurodegenerative disorders for this patient.
Neurodegenerative disorders.
The head disappears, there is no ognomegaly, but you said the eyes are quite normal. Any chance for neurodegenerative disorders for this child?
Yes, sir.
Which neurodegenerative disorder you consider?
Sir, with
Any startling response?
large head circumference, Canavan's disease, mucopolysaccharidosis.
MPS, but you mentioned this, but the eyes are quite normal. You said hearing is any chance for Tay-Sachs?
Yes, sir. Tay-Sachs is
Any startling? Eyes are normal. Any startling? Somebody is asking whether abnormal startle or not. You didn't mention about that.
No, sir. No, sir. Startle response is normal.
You look for that. Do you look
yes,
for
sir.
that?
I mentioned that, sir.
Okay, you mentioned. Sorry. So do you want to consider? That's what I'm asking. You said there is. You use the word regression is there. That's why I'm
Yes,
very particular. Whether is it a neuro regression, neurodegenerative disorder?
Sir, since seizures are also present, there is possibility of gray matter disease.
You are consider gray matter disease, and you will work for that. If you consider which gray matter, which neuro disorder you consider, because large Alexander's and Canavan's or Tay-Sachs.
Sir,
but the reflex plantar is downgoing, not upgoing. The white matter is not involved. Anyway, that you consider that as an option. neurodegenerative disorders.
Yes, sir. Neurodegenerative
So
disorders can also be a possibility in this
so
type.
at the end of this session, at the your thoughts are either chromosomal anomaly or a neurodegenerative disorders or any neurocoordination syndrome. Is the three possibilities that you consider at this stage?
Yes, sir.
And now let us know what's the next plan.
Sir, and values investigated and routine investigations done, blood investigations were normal. But EEG done showed frequent multifocal high amplitude spike and wave pattern with and sharp discharges involving bilateral frontal and left occipital region, which is
That's
suggestive
what-
of hypsarrhythmia
Yeah.
pattern.
Oh, okay. Chaotic pattern.
Yes, sir. On a chaotic background.
Hearing is normal. MRI.
This was the EEG done.
Oh,
And MRI done showed pachygyria, which is likely to represent lysencephaly type 1s.
okay. Listen carefully.
There was decreased number of gyri and sulci.
So you've done the whole exome sequencing also.
Yes, sir.
What does it
Since
suggest?
we saw lysencephaly type 1 on MRI, we did a whole exome sequencing, which was suggestive of Miller-Dieker lysencephaly symptoms.
Okay. So, okay.
This was the MRI done, which showed lysencephaly, and the report of whole exome sequencing.
So the diagnosis came. So whether our clinical discussion was useful to reach a diagnosis, or your diagnosis picked up by this MRI?
No, sir. We did this whole exome sequencing only because on MRI we saw lysencephaly.
No, I'm not against that. You're doing this whole exome sequencing, or but clinically we consider the possibility of chromosomal anomaly and structural malformations, and then we have ruled out inborn metabolism. We have ruled out which condition? Intrauterine infections. We have ruled out by history and clinical examination. And then the one that remains is either neurocoordination syndrome, but there are no other clinical features. And
No neurocoordination markers were
Okay.
present. We considered neurodegenerative diseases and
now for this family, what are you going to do? How are you going to manage this child for the present problem?
sir, West syndrome was managed with initially with ACTH. 2 doses of ACTH injection was given at 14
What is the
international
dose?
units.
What is the dose that you're given?
Sir, we use the standard dose 150 international units per meter square per day. And 40 international units were given, and which was gradually tapered after a
When you're
period of
giving ACTH, how will you
7 days.
monitor the patient?
Sir,
How will you monitor the patient when you're giving ACTH?
sir, close monitoring of his blood pressures were done, and
Pressure
child
and
is found to have
pressure and glucose.
TRBs also was monitored. Sir.
Okay, then.
TRBs was normal, but child was found to develop hypertension, which was managed with nifedipine.
Okay. What is the dose of nifedipine that you're given?
Sir, nifedipine was given at a dose of 0.5 mg.
0.3 to 5
Okay.
milligram per kilogram body weight. Okay, then.
Yes.
So then vigabatrin was added.
Yes, sir. Later, vigabatrin was started at 50 milligram per kg per day, sir.
Main side effect of vigabatrin.
Sir, I couldn't side.
What is the main side effect of vigabatrin?
Sir, retinal.
Somebody is answering. Okay.
Sir, retina could be affected. Retinal toxicity.
That's the vague statement. What that say?
Scotomas.
Yes, somebody is
vision
answering.
can-
You see the chat box. So you can see the visual defect. It's a visual problem. It's maybe difficult to assess this vision in young children when you are using vigabatrin. Vigabatrin is a good drug for this tuberous sclerosis induced best
If it is tuberous-
cases, but this is the main problem. Okay, then. Currently, child is on vigabatrin and developmental therapy and subsequent follow-up. So now, the fate of this patient is not going to be very rosy. Now the parents are asking, what about the future? In which way are going to do genetic counseling for this family? which we are going to give genetic counseling for the family. Alvin.
Thank-
Hmm?
So the
Pardon?
nature of the disease should be explained to them,
Pardon?
and sir, parents should be counseled about the nature of the disease and prognosis. Usually,
How long these children, you have a diagnosis, how long these children live? What is the life expectancy of this child?
sir, life expectancy is poor, sir. They usually don't reach
Bye-bye.
their adolescent age.
Eh?
Sir, usually they by 2 to 3 years, prognosis
2
is
years,
poor in
okay.
case of
So what about the future pregnancies for the family?
what are the
Future pregnancy.
future pregnancy? There are mostly it can be autosomal dominant, and there are also reports of sporadic cases of Miller-Dieker syndrome, sir.
So whether they can she can conceive again, and if you conceive again, whether
There is a 25% chance of
how much?
25%.
25?
Sir, sorry, sir. There is a 50%
50% chance. So how are you going to manage the situation? So how are you going to manage during the first trimester? Any other test that you will do to know whether the baby is affected or not?
Sir,
Any other test that you will do? Whether you will say that, oh, let us try, let us wait until the end.
sir,
Jovin Chris Anthony, she says something. Amniocentesis can be done. And if
Village sampling.
we can do the fish, I can see if the baby is affected. We can up to what is nowadays termination is recommended. A pregnancy.
Termination is recommended up to 20 weeks now, sir.
20.
20 weeks of
Little more.
20,
No recommendation.
22.
No. 24. Latest recommendations of 24 weeks. Am I right or not? Whether that's by belief, 24 weeks. So the prognosis is not that rosy for this child. Anyway, we're quite unfortunate. It's an autosomal dominant condition, and you have to do the 24 only, sir. Okay, correct. So you do that. That's the only thing that you can offer for this family. Anyway, now the session is open for discussion. Very important people like Purushottam sir is there. Sir, your contribution, sir. Purushottam sir, are you there?
Yes, sir. Yes, sir. I was, sir.
Alvin, can you stop sharing?
Sir,
Stop
So
sharing.
please stop sharing, and please on your video also.
Sir, your suggestions, Purushottam sir.
Regarding Alvin and other postgraduates, you should be ready for both type of presentation. Here, you already prepared for a presentation starting from the pregnancy rather than the presenting complaints under past history. Here, when the examiner wants the details in the other way, you should be ready for that type of presentation also. So that was lacking. Sir was asking the details of the presenting complaints, and that part was vague. You are attempting always to go back to the other presentation only. So whenever a PG is presenting, you give importance to what the teacher or the examiner asks. So when he wants the details of that, you should be ready to give the presentation in that manner also. That was one point. Another one, the development, I think it's not you can't say it's a regression, because the pattern of the growth is not supporting the rules of the development. There is something called basic rules of development. Here you're telling 4 months child achieved, head control achieved, rolling over achieved, and 3 months there was cooing. And the very same manner, there is no social smile. And by 5.5 months, a regression. So something is wrong there. most probably he didn't achieve the 4th month head control and turning and all. So when you present the development, you should be going back again and again. If it is not supporting the basic rules of development, there is something wrong in that part. Then about the possibility, when you're sure, sir was telling, that's the main reason why sir was insisting on what exactly are you getting in the presenting complaint. Is it an abnormal movement? Is it a seizure? What type of seizure? The seizure of semiology. So in a case, it's something lasting just for seconds in groups. That is a classical age. So that is usually a myoclonic type of seizure that is occurring somewhere around that 5-6 months. So of course, 90% of the possibility may be the West syndrome, but underlying problems, always keep in mind, the perinatal asphyxia, intrauterine infections, out of the metabolic errors, phenylketonuria. So, and some of these structural problems like agenesis of corpus callosum. These are the entities which should be considered. So, as sir said, the birth weight was very important and the antenatal, natal, perinatal, everything was normal. HIE unlikely, intrauterine infection unlikely, but one possibility is always a metabolic error, phenylketonuria. So in the family history, you need to be considering that point. And in the examination, at that point itself, the smell was to be insisted and stressed on. The hair color was to be stressed on. And those things were not, you didn't consider that possibility of underlying phenylketonuria and metabolic errors at that stage itself. Of course, after that, baby was gaining weight very well. It's a point arguing against the inborn metabolism, of course. And when you started the measurement again, that was not at all fitting with this thing. See, in Kerala, in our situation, don't expect the baby to be 7.5 at 5.5 months and your comment is very undernourished. That's not right. Because as sir said, double the weight gain. The child's weight gain is fairly good. It's not a totally unhappy situation. The length part also is not that. 60 is almost right. So both the weight, height part about your comment was not right. About the head circumference, it is 41, a little on the lower side because you expect 43. So even though it is not satisfying microcephaly, 3-dimensional, it's significant always. Head circumference is so important. Sir was talking about one of the possibilities which starts the macrocephaly. Anyway, you can say it's not macrocephaly, it's not supporting Tay-Sachs or the other entities like Canavan or Alexander, all those things. And one more entity is the glotaric acidemia situation where your movement is not myoclonic seizure, it's an abnormal movement. So all the situations, head circumference is so important. And whenever you mention about head circumference, always talk about the maternal head circumference. That is not, didn't mention that. So, that is very important. Other thing is, postgraduate students are basic decency. Mic is off ചെയ്യാണെന്നുള്ള കാര്യം പറയേണ്ട ആവശ്യമില്ലല്ലോ. എന്താ ഇവിടുത്തെ ആൾക്കാർക്ക് എന്താ മനസ്സിലാവാത്തത്? ബാക്കിയുള്ള കൂട്ടരെ ഡിസ്റ്റർബ് ചെയ്യാൻ പാടില്ല. അങ്ങനത്തെ കാര്യങ്ങൾ സാമാന്യ മര്യാദയാണ്. യു ആർ ഓൾ മെജോറിറ്റി ഓഫ് PG സ്റ്റുഡൻസ്. ഇവിടെ കാണുന്ന കാര്യം ഞാൻ സാറിന്റെ അടുത്ത് പറയേണ്ടെന്ന് വെച്ചാൽ ഇറ്റ്സ് എ വെരി ബാഡ് തിങ്. പോസ്റ്റ് ഗ്രാജുവേറ്റ് സ്റ്റുഡൻസ് ഡിസിപ്ലിൻ ഉണ്ടാവണം. അതില്ലാതിരിക്കരുത്. മൈക്ക് ഓഫ് ചെയ്യണം. The other thing is, when you mentioned about the neurocutaneous markers, of course, one of the possibilities is a tuberous sclerosis. There again, mentioned watch the parents. It's not enough to see the neurocutaneous markers on the body of the child. Only always look at the parents. Sir was talking about the father illness. That is very important. What is the IQ of the father? What is his occupation? So all these things are indirectly having a bearing on the conditions. Of course, the clinical examination, sir was discussing very well. The hypotonia part. When you get a hypotonia, it's a central hypotonia. So central hypotonia, hyporeflexia situation, there are possibilities you need to consider. Sometimes there are rarer possibilities of peripheral plus central entity. Hypothyroidism, one of the treatable entity, but the macronic issues are unlikely. So other things, muscle disorders and the brain involvement. So that is one thing where your tongue, your cardiac examination and the liver. It's very important. In the cardiac examination, both ways, IU infection, there will be structural problem. Muscle disorders, there will be muffling and cardiomegaly. So these are all very important ways. Well discussed, sir has gone in depth about the most of the problems. And when I was suspecting, when there is structural dysmorphism, I was suspecting a cerebral malformation as a possibility, and I was considering agenesis of corpus callosum rather than the lysencephaly. So that was my clinical judgment because there was a dysmorphism. In the context of dysmorphism, possibility of a cerebral malformation highly likely, and in the myoclonic seizure situation, you expect a agenesis of corpus callosum. One of the other entities in the fundus, always consider coloboma and Aicardi syndrome. The other things are all mentioned. Jose, ഞാൻ ചീത്ത പറഞ്ഞോണ്ട് കുഴപ്പമില്ലല്ലോ.
ഒരു കുഴപ്പമില്ല.
സാറ് പറയണം. സാറ് ഇങ്ങനെയുള്ള കാര്യങ്ങൾ പറയണം. നമ്മൾ പല പ്രാവശ്യം പറഞ്ഞിട്ടുള്ളതാണ് പീജീസ്.
അതിന് അറ്റൻഡൻസ് ഉള്ളതാ.
Basic courtesy. Basic courtesy. That's certain things that they all should practice. Switch off, mute your mobile, because so many people are there. When so many people are there, should be very, very stringent. So no casual talk, nothing.
ഇല്ലാത്ത ആൾക്കാർ ഇനി ക്ലാസ്സിന് കയറണ്ട. ഇല്ലാത്ത കൂട്ടർ കയറണ്ട. ബെറ്റർ നോട്ട് ടു കം ടു ദ ക്ലാസ്. പേര് മതി.
അവര് മനസ്സിലാകുന്നില്ല. അവര് വീട്ടിലുള്ള കാര്യങ്ങൾ മുഴുവൻ പൊതുവെ അറിയുന്നുണ്ടെന്ന് പോലും അവർ അറിയുന്നില്ല.
അതാണ് കഷ്ടം.
അതാണ് കഷ്ടം. അതിനേക്കാളും
Anyway, sir, thank you so much, sir.
Thank you, Jaykumar sir, and thank you, Purushottam sir. Jaykumar sir, as usual.
Also to Alvin, you have done a wonderful job. And also the mentor, Jacob sir, and also Leather Madam in her absence, I am telling.
Madam is there, sir. Leather Madam is also there, sir.
Jaykumar sir, നമ്മള് വളരെ അവസാന നിമിഷത്തിലാണ് വിളിച്ചെങ്കിൽ സാർ അത് സാർ എനിക്കറിയാം സാർ ഭയങ്കര ബിസി ആയിരുന്നു. പക്ഷെ ഇത് done a wonderful job. Thank you, Jaykumar sir. Jacob sir.
ജോസ് പറഞ്ഞ എന്തെങ്കിലും ഞാൻ ചെയ്യാതിരുന്നിട്ടുണ്ടോ?
ഇല്ല അതൊക്കെ അതുകൊണ്ടല്ലേ പറഞ്ഞത്. താങ്ക് യു സർ. ജേക്കബ് സാർ, ഞാൻ പറഞ്ഞ നമ്മുടെ ഒരു ഡിഫിക്കൽട്ട് സിറ്റുവേഷൻ ജേക്കബ് സാർ വളരെ ആക്റ്റീവായിട്ട് നമുക്കൊരു കേസ് എടുക്കാനും നല്ല ആൽവിൻ വളരെ ബ്യൂട്ടിഫുൾ ആയിട്ട് പ്രസന്റ് ചെയ്തു. കൺഗ്രാറ്റുലേഷൻ ആൽവിൻ. ആൻഡ് ഓവർ ടു ഷാനവാസ് sir for comments. Shanavas sir.
So nothing more to add. So it was a very wonderful discussion, and last thing, that is നമ്മളിപ്പം critical comment എന്ന് പറയുന്ന പോലെ it was a very good analysis of whole discussion was also done very well. It was a very enjoyable. I think full time I was listening to sir. Each point it is discussed. എല്ലാത്തിലും questions. That is the way usually some of the examiners used to ask. So if you can answer sir's questions, you will never fail in any exam. Okay. Thank you very much, sir.
Again, thank you, Purushottam sir, for presenting and giving the critical analyzing all the aspect of presentation and what the positive thing, what the negative thing, everything. Every after I think thank you, sir, for attending.
Thank you, Shanavas. Thank you very much.
Thank you, sir.
Shanavas, thank you.
Okay, sir. Thank you. Good night. Okay.
Over to Biniputan for final comments and conclusion.
Darli Madam is there. Darli Madam, any comments?
No comments. Nothing more to add.
Thank you, Jaykumar sir, for that excellent discussion. Like that Shanavas sir said, for every sentence there was a question, and we really learned from this. And congratulations to Dr. Alvin, presented the case in an excellent manner. Thank you, Jacob sir, for mentoring. And thanks, Purushottam sir and Darli Madam for the comments. So thank you everyone for
very good attendance also. It was very good attendance also.
Okay. Good night.
അടുത്ത ആഴ്ച കാണാം.
Good night. അടുത്ത ആഴ്ച കാണാം.
അടുത്ത ആഴ്ച കോട്ടയക്കാർ ഇറങ്ങും അല്ലേ? ഡാർലി മാഡം.
അടുത്ത ആഴ്ച ഞങ്ങളെ കോട്ടയാണ്.
Okay. Thank you.
Thank you. Good night.